Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic.
And then Irma, I'll give you a minute if you wanted to do the introduction for tonight.
Hi, Rebecca. Good evening. It is my pleasure to introduce our speakers for the evening. Their session is titled The ECHO Approach for Children with Neonatal Abstinence Syndrome. Our speakers tonight will be Cindy Io, OTD-OTRL. Cindy earned her Bachelor of Science degree in Occupational Therapy from the University of Alabama at Birmingham, followed by her post-professional Doctor of Occupational Therapy from Rocky Mountain University of Health Professions. Cindy has over 28 years of clinical experience serving clients across the board, from pediatrics to geriatrics in acute care, intensive care units, outpatient clinics, subacute rehabilitation, home health, and early intervention. Cindy also works in academia, educating OT students in a multitude of areas. Neha S. Tripathi, OTD-OTRL CDP, has over 10 years of combined experience as an OT in India and the United States. She completed her Bachelor of Occupational Therapy from India, followed by her Master of Science degree, as well as post-professional Doctor of Occupational Therapy degrees in the United States. She is a certified SVT provider and a certified dementia practitioner. She is full-time research faculty and assistant professor in the OTD program at Wingate University in North Carolina, and an adjunct assistant professor professional OTD program at Valparaiso University in Indiana. Although most of her professional experience has been in geriatric rehabilitation and complex disease management, she holds a keen interest in OT education and collaborative research at the national and international levels. She is an active member of the core team involved in worldwide education and innovation for the CAWA model in occupational therapy. So it's our pleasure to have you this evening, and we will begin.
Thank you, Irma. Good evening, everyone. My name is Neha Tripathi, and I'm presenting today with Dr. Cindy Ayo. We are presenting on the ECHO approach for neonatal abstinence syndrome. I am an occupational therapist from the Washington, D.C. area, and Cindy lives in Knoxville, Tennessee. While I do have some experience working in pediatrics, most of my work has been in geriatric rehabilitation and complex disease management. And my core interest, although, has always been in research and program development. But Cindy is the real subject expert here with more than 3 decades of OT experience behind her. the neonatal abstinence syndrome was the central topic for Cindy's doctoral capstone project. And after we both graduated from our doctoral program, we got together, bringing our individual skill sets together to build this innovative approach called the ECHO approach, the early collaborative holistic occupation-focused approach for intervention with children and infants with neonatal abstinence syndrome. I'm just going to start sharing my screen here. So just taking a quick look at our objectives. By the end of the session, you will be able to demonstrate an understanding of what NAS is, what are the neurodevelopmental complications associated with it, and the areas of occupational performance that are impacted across a child's lifespan when they have neonatal abstinence syndrome. You will also be able to demonstrate an understanding of the ECHO treatment approach to achieve optimal independence with daily occupational performance for children with NAS. And you will be able to identify relevant evidence-based OT treatment interventions and strategies for multidisciplinary collaboration based on this ECHO approach, which will be introduced to you to address the various neurodevelopmental conditions associated with NAS. A quick look at the outline of today's session. We're going to start with discussing the incidents and risks associated with prenatal drug exposure. We will talk about how preterm birth and neurodevelopmental complications and NAS occur when an infant is exposed to drugs in utero. We will also discuss some complications associated with specific drugs. And then Cindy will take over from there, discussing the client factors, performance skills, and areas of occupation that are affected. We will then introduce the ECHO approach and the interventions outlined under this approach, which include early intervention, sensory integration, perceptual motor, developmental play, cognitive interventions, social emotional interventions, and behavioral interventions. And then Cindy has some interesting case studies to discuss to conclude the session. So coming to what actually neonatal abstinence syndrome is. When an infant is exposed to drugs in utero, when these drugs enter the bloodstream of the infant through the bloodstream of the mother who is exposed to drugs, this infant also develops an addiction to that drug. At the time of birth, there is a sudden withdrawal of that drug from the infant's bloodstream. And that leads to a constellation of health issues with immediate and long-term consequences. This syndrome is called neonatal abstinence syndrome. Now, why do we need to talk about it? How common is it? In the United States, there is an increased incidence of NAS, which is demonstrated by some staggering statistics. In 2016, one child was born every 25 minutes with neonatal abstinence syndrome. This was a 5-fold increase from the year 2000 to 2012. By 2018, one child was born every 15 minutes with neonatal abstinence syndrome. This was a 7-fold increase from the year 2000 to 2014. In Georgia, the incidence of NAS has steadily increased between 2010 and 2015. 6 out of every 1,000 live births are diagnosed with NAS. And this increase in the diagnosis, the incidence of NAS, corresponds with the increased use of opioid drugs when pregnant. About 18 to 22% of women report using some opioid when pregnant. So just imagine that's about 1 in 5 pregnant women who are exposed to drugs, to opioid drugs when they are pregnant. About 5.1% of pregnant women in the reproductive age group report using illicit drugs, and about 11% is the reporting statistic for cocaine use during pregnancy. Now, these are the reported statistics. The actual drug use statistics are definitely much higher than this. Now, why is that? Why is the reported statistic lower than the actual statistic? We'll talk about that in just a second. Now, the incidence of NAS, the diagnosis of NAS, is associated with an average hospital stay of about 17 days at the cost of $2,700 per day for a NICU stay. And most of these infants do end up in the NICU. The diagnosis of NAS can occur in a period of about 5 days, up to a period of 5 days after birth. And the severity of the NAS symptoms depends on the type of drug used, on the duration and the timing of the drug exposure. Interestingly, infants who are born preterm show less severe symptoms of NAS, and that could possibly be because the duration of drug exposure is cut short due to the preterm birth. Now, coming back to that question about why is there a lack of reported drug use during pregnancy? Why is the reported statistic so much lower than the actual statistic? It is because these mothers may have a fear of prosecution. They may fear the loss of freedom because of the drug exposure to their unborn infant. They may fear losing their job, losing their income. They may fear losing their child or being separated from the child. And of course, there is a huge stigma associated with drug use during pregnancy. Because of this stigma, a lot of these mothers will not report their drug use. They will not report medical conditions and put themselves and their infants at risk. Now, what are some of the effects of prenatal drug exposure in utero? When an infant is exposed to drugs in utero, these drugs have the ability to cross through the placenta into the infant's bloodstream. They cross the fetus's blood-brain barrier and affect fetal brain development. Drugs are also known to cause vasoconstriction, thus restricting the oxygen supply to the brain, and that affects the neurotransmitter levels in the developing brain. Most of the brain development, most of the neurosensory development occurs in the final 16 to 20 weeks of gestation. And at this time, when an infant is exposed to drugs in utero, that affects the neurosensory development of the brain, which affects the various lobes of the brain as they're developing. If the frontal lobe is affected, that affects motor development, memory, and cognition. If the parietal lobe is affected, that will lead to deficits in perceptual skills, sensory integration, sensory awareness, all of the functions of the parietal lobe. If the temporal lobe is affected, that will affect auditory perception and other perceptual skills. Now, what are some of the risks associated with drug use during pregnancy? Of course, there is maternal stress from all of the factors we talked about, such as the fear of prosecution, the fear of losing freedom, the fear of losing a steady source of income, the fear of being separated from the child. Because of the stigma associated with drug use during pregnancy, a lot of these women do not get timely and appropriate treatment for their medical conditions. There is also widespread malnutrition amongst these women. They lead complicated lifestyles that are rife with violence, poor social support systems, unstable incomes, and inconsistent and labile day-to-day routines that affect not only the mother, but also the unborn child and later the infant after being born. Because of drug use during pregnancy, you commonly see things like preterm births, low birth weight, and short-term and long-term complications. Now, let's talk about preterm birth. Any infant that is born at less than 37 weeks of gestation is called a preterm birth. About 13% of all live births are preterm. And the fact that an infant is born preterm already affects the cerebral white matter development of the brain. But also there is a huge factor that affects the infant's brain development even more. And that factor is being admitted to the neonatal intensive care unit, or the NICU. A lot of the infants that are born preterm end up in the NICU, and there are some environmental stressors in the NICU that affect the infant's brain development even more. These environmental stressors include bright lights, constant noise, the constant nurse handling, the repetitive pain that occurs in the NICU. All of these lead to neurodevelopmental complications as the child's brain is affected because of these stressors. The same, the development of the frontal, parietal, and temporal lobes is affected, which gives rise to neurodevelopmental complications later on, depending on the functions of those lobes of the brain. Next, we come to the neurodevelopmental complications that are associated with preterm birth. So as you can see, it affects almost every, it affects function at almost every level. Cognitive delays and executive functioning deficits are seen in infants with preterm birth. There are behavioral impairments, ADHD, ASD may be diagnosed later on. There are motor developmental delays, visual motor integration problems, both of which affect their ability to play and explore their environment. In the school, you might, in addition to the ADHD and the ASD, these children might be diagnosed with learning disabilities and sensory processing difficulties. Some of the short-term complications that are associated with drug use during pregnancy are tremors, irritability, weight loss, seizures, feeding patterns, and digestive difficulties. And these are just the short-term ones. The long-term complications include all of the performance areas affected, such as motor development, cognitive abilities, the visual motor integration problems, social emotional development, behavioral regulation, and attention. So you can see that almost every system is affected, whether it's short-term or long-term. The autonomic and the central nervous system definitely show the most complications. The ANS shows complications such as impaired heart rate, most commonly tachycardia, which might progress to arrhythmias. There's also an increased respiration rate, mottling of the skin due to circulatory compromise. You might see excessive sweating or sneezing, yawning, and fevers in these children. And the CNS complications of neonatal abstinence syndrome include hypertonicity, seizures, tremors, and irritability. Irritability is probably the most common thing, which is characterized by this high-pitched cry, which is very commonly seen in NAS. And of course, this syndrome also affects the gastrointestinal system. Very commonly, you see weight loss or poor birth weight. Poor feeding patterns are a common complaint. Diarrhea, vomiting, and regurgitation are commonly seen. And these infants will often present with an inordinate amount of sucking. That is a kind of non-nutritive sucking, and that results from the inability to self-regulate. And this is usually an attempt on the part of the infant to calm itself down as it struggles to adjust to the external stimuli. And then there are some developmental complications that you see as the infant grows. These infants have difficulty integrating sensory input. They will either under-respond or over-respond to stimuli in their environment. They might have impaired self-regulatory skills. So you might see things like excessive crying, jitteriness, irritability, that high-pitched cry, poor sleep patterns. And in addition to that, you'll see things like impaired motor control and poor muscle tone. They might show uncoordinated movements, hypertonicity, or tremors. And all of these things will lead to performance patterns that are not in line with the normal development of an infant. You will see poor positioning, poor feeding patterns, poor environmental interaction, poor caregiver bonding, all leading to several developmental complications that might last almost the entire lifespan of this infant. So how is NAS managed? First, let's look at the medical management. Medical management occurs at two levels, at the NICU level and at the long-term intervention level. In the NICU, medical management is through medications, environmental adaptations, and using a multidisciplinary approach. After discharge from the NICU, experts recommend following up with long-term intervention. These include early interventions using a multidisciplinary approach, continued medical follow-up with the medical team, caregiver support, and environmental adaptations. Now we come to the complications of specific drugs that may lead to NAS. In particular, we'll talk about opiates, cocaine, cannabis, tobacco or nicotine, and alcohol. So opiates include both heroin and opioid medications. Here's a statistic. In 2018, medical providers in the state of Georgia wrote 63.2 opioid prescriptions per 100 persons. And that is much higher than the national average of 51.4 prescriptions per 100 persons. So definitely more than 50% people who go to a medical provider are getting opioid prescriptions. Now, the problem with opiates, the use of opiates when pregnant is that opiates are water soluble. They easily transfer across the placenta into the bloodstream of the infant, of the fetus. They are able to cross the blood-brain barrier and affect neurotransmitter production, altering the synaptic activity in the developing brain. This increases enzyme activity and affects the various lobes of the developing brain. Heroin is known to be a vasoconstrictor. It restricts the oxygen supply to the brain and slows down or stops its development. The medical complications of opiates, surprisingly, are more severe than cocaine, even though opioid medications are so commonly used. Of course, it leads to NAS, a diagnosis of NAS. You will commonly see preterm birth or low birth weight in infants who have been exposed to opiates in utero. SIDS, or sudden infant death syndrome, is also commonly seen with opiate exposure. There is a high incidence of decreased head circumference or microcephaly, and CNS changes, GI difficulties, all of which are associated with opiate exposure. And some of the neurodevelopmental complications associated with opiate exposure include a diagnosis of intellectual disability, which often occurs when the infant reaches school age. There are cognitive developmental delays, diminished verbal and academic skills, including math and reading. Behavioral issues such as disruptive behaviors and delinquency are commonly seen with prenatal opiate exposure. A diagnosis of ADHD and motor delays is often made with these infants. Now, when an infant is exposed to opiates in utero, to treat this addiction for the mother, often two drugs are used, methadone and buprenorphine. Methadone is the more traditional drug that has been used with mothers, with pregnant mothers who have been using opiates of some kind. It's been used since 1964. Methadone has been used for a long time. But this drug itself has side effects, which include an increased incidence of NAS, It can lead to diminished motor control in the infant, decreased IQ, hyperactivity, limited attention span, and behavioral regulation difficulties and impaired social engagement. Now, the drug itself, opiate, as a drug might also cause NAS, and the treatment that is used for opioid addiction may also cause NAS. So it's a really tricky situation. But you have this other drug called buprenorphine, which is also another alternative to used for opioid addiction. It has been associated with a decreased risk of NAS and a decreased length of hospital stay. So it is definitely a more acceptable drug. However, the catch is that buprenorphine has been shown in research to have a higher risk of maternal non-compliance. So again, that presents a tricky situation because you might not have as much compliance with buprenorphine as you do with methadone. Now, the next drug that might lead to NAS is cocaine. Cocaine is a known psychostimulant. It crosses the placental barrier and is a known vasoconstrictor, thus restricting the oxygen supply to the brain. And if it affects neurotransmitter levels, in particular, it stimulates dopamine receptors in the brain. It alters CNS development by affecting the white and gray matter in the hippocampus and the amygdala, both of which are responsible for emotional regulation. And it also affects the frontal lobe, which is responsible for executive function, memory, cognition, and motor development. The medical complications of cocaine include preterm birth with low birth weight, diminished fetal growth and microcephaly, CNS changes and restricted development, and a diagnosis of NAS. Now, the neurodevelopmental complications of cocaine are vast. They include everything from a diagnosis of intellectual disability to language delays and executive function difficulties, behavioral dysfunctions, including impaired sleep patterns, impulsivity, risky behaviors, delinquency. They may also include social emotional delays, problems with self-regulation, diagnosis of ADHD, or oppositional defiant disorder, or ODD, anxiety and depression. It also affects visual motor skills, including attention span, processing speed, visual memory, and it is known to cause motor developmental delays and impaired muscle tone. The next drug that also causes NAS is cannabis. Now, according to 2010 statistics, cannabis is the most abused substance in the United States, even more than alcohol or opioids. Cannabis is the #1 abused drug, and this is overall, not just during pregnancy, but it is also very commonly used by women during pregnancy. It is known to cause vasoconstriction, and it also is able to cross the placental barrier, affecting the neuronal and synaptic formation in the fetus. Some medical complications associated with cannabis are preterm birth, low birth weight, congenital abnormalities, decreased cortical gray matter, and NAS, almost similar to the medical complications you see with the other drugs like cocaine. And the neurodevelopmental complications, again, are as vast as we just saw with cocaine. It's almost the same complications that affects everything from cognition to motor development to emotional behavioral difficulties and motor delays and social developmental delays. Now, the next thing is that affects NAS is tobacco or nicotine. Now, nicotine is a vasoconstrictor. It crosses the placental barrier and binds with receptors in the CNS. Interestingly, it is associated with more severe brain impairments than prenatal cocaine exposure. And come to think of it, tobacco is such a socially acceptable substance out there in society. A lot of people use tobacco. Pregnant women, almost 16.4% women report using tobacco during pregnancy, and that is not counting the secondhand exposure that occurs on almost a daily basis with tobacco. The medical complications of tobacco or nicotine are, again, similar to cocaine or cannabis: preterm birth, low birth weight, decreased head circumference, a diagnosis of NAS and SIDS. And the neurodevelopmental complications, again, span everything from cognition to intellectual and learning disabilities, hyperactivity and behavioral problems, social, emotional, developmental difficulties, problems with self-regulation, depression, anxiety, and decreased visual motor control. The next substance that we're talking about is alcohol, another socially acceptable substance, but it is the most abused substance during pregnancy. The number one abused substance is alcohol, and the next is tobacco, followed by cannabis. So alcohol is a known CNS depressant. It decreases cortical and subcortical activity. It crosses the placental barrier, and it blocks the growth factor hormone receptors in the brain. The medical complications of alcohol include fetal alcohol spectrum disorder, a diagnosis of NAS, low birth weight, microcephaly, CNS damage, and specifically damage to the HPA axis, which is the hypothalamic pituitary adrenal axis. It is commonly associated with the diagnosis of intellectual disability, and craniofacial deformities are often seen in children with FASD, or fetal alcohol spectrum disorder. Again, the neurodevelopmental complications of alcohol are similar to any other drug. It is not less severe or more safe than any other drug like cocaine or heroin or opioid medications. It can affect intellectual abilities, executive function, behavioral regulation, motor development, coordination, visual perceptual skills, handwriting and academic skills, postural stability, and a lot of the motor, visual, motor developmental delays that are seen in alcohol exposure are often attributed in research to the decrease in isotonic force production that occurs when an infant is exposed to alcohol, when the developing brain is exposed to alcohol in utero. So these are some of the problems, a lot of the problems that we see with drug exposure in utero. You can see that no drug, whether it is a socially acceptable drug such as nicotine or alcohol, or something seen as a hard drug like cocaine or heroin, none of these are better than the other. They are all equally harmful to the developing fetus. I'm going to stop sharing my screen here, and I'm going to ask Cindy to take over.
All righty. Wow, right? Quite daunting to look at all the complications associated with children that have been exposed to drugs in utero. You know, the statistics are quite scary and alarming. When we look at children that are exposed with drugs in utero, as far as the diagnosis of NAS, often you'll see it used with a child when they're in the hospital, when they start to demonstrate withdrawals. But not every child that is exposed to drugs in utero may develop those withdrawals or just demonstrate symptoms, or may not be diagnosed with NAS. but they may still have some of these long-term neurodevelopmental complications. Again, we don't know every child that's been exposed to drugs in utero. One research article talked about of the percentage of women that tested positive for using cocaine, only 11% of them actually admitted to using the drugs. So we really don't know the true statistics of how many kids have been exposed to drugs in utero. But if you are working with a child and that's something that we find out is a past medical history, I think it's so important for us to be aware of a lot of the different complications that may be associated. One of the articles I read talked a lot about, a lot of it has to do with when the fetus was exposed to drugs in utero, whether it was early or later in pregnancy and how much. And we don't know for which drug what you will see. It could be a combination and the severity could vary from child to child. So some of the client factors that we see that's associated with exposures to drug in utero, of course, if we look at the body structures, as Neha beautifully put it, it affects so many areas of the central nervous system, both the gray matter and the white matter development. It also can develop, implement, and affect the child's growth. Several of those different drug exposures was associated with microcephaly. As far as body functions that we can see that can be affected by drugs in utero exposure, sensory functions, their mental and executive function, the endocrine system, the neuromuscular functions, along with perceptual skills. As far as the different functional skills, y'all saw that it affects so many areas. The executive function, working memory, fine motor, gross motor, social, emotional, eye-hand coordination, sensory processing, visual motor, attention, visual memory. So you can imagine if we've got all these different areas that could possibly be impacted by a child that's been exposed to drugs in utero, think about occupational performance. And we as OTs, what do? Occupational performance. So if you look at these kids or infants that have been exposed to drugs in utero, it can start when they are born. It can affect their rest sleep cycles because of the irritability. They often have a hard time with sleep. They also can affect their social participation with the bonding because of the different problems they're having with withdrawals and the drug exposures. And it can affect their ADLs, their ability for feeding, the suck-swallow coordination. And as the child grows and develops and starts to develop more social participation, we know that it can impact that. It definitely can impact their activities of daily living because of the cognition, the visual perception, the fine motor, the gross motor. It can affect their ability to play. We all know how important it is for emotional regulation, for fine and gross motor in order to be able to explore and play. And on into developing and implementing or affecting their IEDLs. If you've got a child that is having some difficulty with executive function, we know how important executive function is for those higher level instrumental IEDLs. And definitely school and education. You know, Neha talked about how children exposed to drugs in utero can have some diminished executive function, can have some learning disabilities, all which can affect education. On into leisure and then into work skills. You know, a lot of the research I did, there's not a whole lot out there as far as across the continuum in the lifespan, but you can imagine if it's affecting these children and there's those cognitive, visual perception, and other life skills, how it can maybe affect them across the lifespan. So what can we do as OTs for these sweet loves? You know, again, like Neha told you, this was something I did for my capstone project, but after talking with Neha, we developed this approach. The ECHO approach, E is for early, C is for collaborative, H is for holistic, O is for occupation focused. We built this off of an article or an approach developed off an article by Reynolds and a group of authors that talked about a multifaceted approach with children addressing sensory integration issues. And after reading it, I realized that a lot of the areas that they discussed are things that we work with children who've been exposed to drugs in utero, and to address the variety of difficulties we may see for these children. The multifaceted approach that was listed by Reynolds in the group, again, the reason I felt it could be applied to children exposed to drugs in utero is because they do have a multitude of areas to be addressed. With the multifaceted approach, it talked about 8 different areas, 7 of which we've included in this approach. One of the first areas it talked about is environmental modifications and adaptations, which we will discuss later. Caregiver education and interventions, which is so important for these kids, and we'll talk about why that's important. We'll also talk about how important it is to focus on the child, because each child is so different. Also looking at behavioral strategies, and as Neha talked about, there are some behavioral difficulties sometimes with these children that have been exposed to drugs in utero. We'll also talk about different developmental and practice interventions for these kids, along with sensory integration therapy, cognitive strategies. The one final component of the multifaceted approach that we don't include in our approach is a biomechanical. But all the other ones are things that we felt were very important to address when working with these children that have been exposed to drugs in utero. They often present with a very difficult or complicated clinical presentation, requiring a multitude of different treatment strategies. But the one thing that I have to emphasize is it's imperative for the OT to do a thorough evaluation and occupational profile, because one treatment approach does not fit all with these kids. We'll discuss several different options of interventions to look at with these kids, but it truly is based off the OT's evaluation and clinical skills to discover or determine what deficit areas are associated with this child in order to know which treatment approach is best for the child. This just gives you some evidence out there to support treatment of different clinical presentations, but it's up to the evaluation and the treatment plan to determine what is appropriate for each child. So let's start with E. All of us as clinicians know how important early intervention is for children. Early intervention often is classified from birth until, I think it's 2 years, 11 months, and 31 days, right before they turn 3. And again, the goal of early intervention is try to help enhance that child's developmental skills, possibly decreasing, I get ahead of myself. I start talking and decrease his or her developmental delays, support their medical health, improve functional performance and independence, and also provide caregiver support. It often begins in the neonatal intensive care for these children who have been exposed to drugs in utero. So we're going to start with talking just a little bit about the NICU. This is definitely a specialty area of OT. You have to have specialized training to work in this area. But I felt I needed to address it with these children who have been exposed to drugs in utero, because this is where often interventions begin. Not always, but often. It's very important. And you're going to hear me as I talk, the ECH and O, they all kind of work together. When I talk about early intervention, I'm going to talk about a holistic approach. I'm going to talk about how important collaboration is, but also addressing occupation. So you're going to see me dip in and out of all of them as we talk, but we'll start with early intervention. So caregiver, family, client-centered care is so important from admission to discharge for these infants. Definitely team collaboration. And when we're talking about team collaboration, oftentimes you've got the neonatologist, you've got the nurse involved. You may have PT, OT, and speech. You may have a nutritionist. You may also have a respiratory therapist. Again, we can't forget the family and caregivers. So you've got a whole team working with that infant. When we're talking about OT interventions, oftentimes we may look at, I like to look at the PEO approach. That's just me. But maybe the P is for looking at the child. Maybe it's positioning and handling techniques. Maybe it's some very basic developmental interventions with the child. We have to look at the E or the environment. Maybe we're looking at lighting or sounding or sounds there in the NICU to help that child. And we may look at occupation. We may look at feeding, and we may also look at sleep patterns and positioning. Family caregiver training and education is so important. Again, when it comes to family caregiver training and education, oftentimes you're working very, very closely with the neonatologists and the nurses, because that, as far as they're being involved, it depends on the status of the child. Oftentimes therapy is not implemented until they're medically ready, until the neonatologist is ready for those type of interventions. But oftentimes they incorporate family caregiver training and education as able. We always try to look at the NICU as kind of a bridge. We want to always consider a bridge between the NICU and the community for the kids as we progress them out into the community. I know I've had a lot of questions, because when we're talking about children that have been exposed to drugs in utero, there's definitely a family dynamic going on there. You may have a social worker involved. When we're talking about caregivers, it may be that there's a foster family involved or another family member involved. So we have to remember, I did not address that dynamic component with this. I mainly addressed evidence-based OT interventions, but there's a lot of information out there about that topic. When talking about working with these kids in the NICU, I just felt like I couldn't talk about that without talking about signs of overstimulation, because oftentimes these children that have been exposed to drugs in utero, we know it affects their central nervous system, and we have to really watch these children's signs of overstimulation. Some of the motor signs we may see is they may spread their fingers, they may kind of go into an extensor posture, they may actually just kind of go limp, like, oh, just leave me alone, I've had enough. Some of the arousal signs, they may kind of stare off or not avoid eye contact with you, become irritable. Some autonomic signs, changes in skin color, changes in heart rates and respiration, hiccups, sneezing, yawning, and gagging. Anytime if I've gotten to the point that I'm seeing autonomic changes, I've done way too much with these kids. Oftentimes I would see, when I worked with the kids, I would see some of the other motor and arousal signs first. You have to watch. If that child's giving you any signs of overstimulation, you need to look at what you're doing. I don't leave those children unattended if they're showing any of the signs. I'm always in communication very closely with nursing, but you've got to read that child's sign. It's so important. That's why training before you work in the NICU is so important. You've got to understand what these kids are telling you. These little infants, that's their body's way of saying, stop. Okay, so I just felt it was important to include those in here. So when we're talking about the NICU and we're looking at the bridging between the NICU and the community, we have to talk about how important the postnatal environment is for these kids. The home environment, we know, plays a crucial role in a child's development, looking at their cognitive skills, their academic skills, communication abilities, social, emotional development, motor development. And if we're working with an infant that's been exposed to drugs in utero, thinking about the postnatal environment, if they're being discharged in a situation where we have got possible drug addiction, we need to realize that we may have other areas that are being addressed by the social worker. Again, I'm not going to go into that. That's something usually the social worker is dealing with, but we just need to be aware of those kind of situations and what's going on. Again, collaborative. We got to work together as a team. Early intervention is a federally mandated program for these children up into the age of right before they turn 3. Again, evidence has shown infants that's born preterm with low birth weight or with developmental delays can benefit from early intervention. And we know that children exposed to drugs in utero are often at risk of being born premature or low birth weight. We do know that early intervention programs can improve the social, emotional, and cognitive and motor skills for children who are involved in early intervention. One real interesting article I read talked about a routine-based early intervention program. It was something I read just recently and wanted to include it. It talked a whole lot about shifting to a family caregiver-centered model. What they did is they kind of switched when they gave a family home activities, they tried to incorporate it into the daily routine. Oftentimes, when you have got a child with maybe special needs, getting therapy services and other interventions, doctor's appointments, it can be very, very challenging to incorporate our interventions into the day. And they found that when they tried to incorporate the interventions into the daily routine, the child demonstrated improved functional outcomes with self-care along with social participation. So it's something I've tried to kind of put in the back of my head saying, you know what, when I give a family activities to do, how can I incorporate into their daily routine? Just because maybe that's something for us to think about as clinicians, to realize there's a lot of dynamics going on with these kids. Again, we know there's a lot of evidence out there to support early intervention. You know, what's the role of OT when we're talking about early intervention? You know, it all depends on the child. What are the needs of the child? Coming back to the OT evaluation to determine, you know, using that occupational profile and performance, looking at the child's strengths and weaknesses, what are their supports, what inhibits, in order for us to address the child's occupational performance. Maybe we're addressing fine motor, gross motor. Maybe we're addressing their play skill abilities and their ability to explore. Maybe we're looking at their social development or behavioral. I don't know. It depends on what the needs of the child is. Again, all to try to enhance their ability for occupational performance and play. One of the articles, it was a meta-analysis that I read that looked at 16 different early intervention studies. They looked at children that were born prematurely and with low birth weight, which of course we know can be a consequence of being exposed to drugs in utero. And they noticed that the children had improvements with cognitive and executive function, movement skills, motor control, language skills, and neuromuscular skills. So again, that just may be, again, including the E with early intervention for these kids that have been exposed to drugs in utero. Whoops, I skipped a slide, sorry. And then C, collaborative. I've already touched on collaborative. When we're looking at collaboration, again, it's a collaboration with all the providers that are involved with that child's care, but also the client, the caregiver, and the family. We all have to work together. Again, these children can present with a multitude of deficit areas and difficulties. We all got to work together to make sure we're addressing all the needs of the child. From the physician, and the physicians could be the neonatologist, it could be the pediatrician, they could have specialists, they may have a neurosurgeon involved or a neurologist involved, they may have a pulmonologist involved, they may have a retinologist involved. Whatever physicians are involved in the care of that child, your nurses, the social workers, PT, OT, speech, developmental specialists. We may have school staff. We may have the teacher. We may have the teacher's aide involved. We may have the school psychologist. We may have community members, behavioral specialists, psychologists, family, caregiver, child. You can see the list goes on as far as who could be collaborative in the care of this child. You know, and it's along the continuum, beginning in the NICU, going until they become little infants and toddlers, and then into school age, and then when they become adolescents and possibly into adulthood, depending on what the needs of each individual person is. You know, to me, when we're talking about collaborative, we cannot forget the involvement of the child, the family, and or caregivers. They're a very important member of the team for us to collaborate in. Again, we already talked about it does start in the NICU. which is a very specialized area of OT, needing specialized training, definitely a collaborative team. Oftentimes they talk about the importance of caregiver training to help with emotional support of a child, to facilitate bonding, and to help transition from the hospital to home. But again, remember, when we're working with children that have been exposed to drugs in utero, we definitely may have an additional component going on where a social worker may be involved. Making sure you're a part of that team to know what's going on is important. Again, we won't go into details today. When we're talking about collaboration, we as OTs can't forget our therapeutic use of self as a tool in the process to help these children, whether we're working with an infant or a child or an adolescent, to help them achieve their occupational performance. We also can't forget the therapeutic relationships that we build, not only with the child and the family and caregivers, but with other disciplines. So we kind of use those tools to help us achieve those optimal goals for those kids. And again, it's all along the continuum of the child. And realize your collaborative role may change as the child's plan of care continues to grow and develop. Depending on what, there may be other team members coming into play. There may be other caregivers that are coming into play. So just realize that we'll continue to be a collaborative team with these kids. And then holistic. When we talk about a holistic approach, it's looking at a multitude of things with these kids. Are we addressing their physical needs, their psychosocial needs, their emotional, their behavioral, and looking at the environmental impact on the child? And when we're looking at the environmental impact, we got to remember that prenatal environment is in fact impacting them postnatally, and realize that postnatal environment can impact them too. So we have to address the whole child when we're working with these kids. And we also have to understand there's an interrelationship of all these different areas that can impact occupational performance. Well, us as OTs, we're definitely looking at the developmental sequence, their development of occupational performance and participation, looking at the multifaceted impact that the drug exposure while in utero is having on that child. Again, the prenatal and postnatal environments, how it can impact them, and the multitude of client factors, performance skills, performance patterns, context, can all affect their ability to perform occupation. Oftentimes with these kids, again, I've mentioned a couple times the importance of the OT evaluation to kind of determine kind of what's going on, but to realize there may be a multitude of things going on as to why the child is having some difficulties with occupational performance. To realize, to me, you know, when I started this process, I had no idea how large it was going to be. I only addressed a few different drug exposures, but there's so many more out there, and there's so much information out there. These children can have such a multitude of things going on. We have to have that holistic approach to see where do we begin and what area may be impacting their occupation. And then occupation focus. That's us as OTs, right? So when we're looking at occupational therapy, again, that's what we're looking at. We're wanting to promote occupation, occupational participation and performance. We may use a multitude of different treatment techniques. We may use preparatory activities. We may use purposeful activities. We may use occupational activities that are meaningful to the child. We are a profession of doing. We want them to try to be involved with doing and becoming and doing activities that are meaningful for them. Again, that's our goal, is occupational performance and participation. I found this quote, I wanted to read it. Occupations are meaningful activities an individual performs to meet their needs, wants within the individual's natural environment in order to facilitate learning and development. That's us as OTs, right? When we're working with these kids who have been exposed to drugs in utero, we have to recognize all the different neurodevelopmental complications that could possibly be impacted by their exposure in drugs in utero, in order for us to address it appropriately in clinic to help with occupation performance. Again, occupation-based, again, we're wanting to definitely look at the holistic picture, what all's going on, looking at the family, caregiver, client goals and outcomes. Again, client-centered, we got to remember that, because each one of these kids present in such a different, with a different clinical presentation. We also want to make sure we're using evidence-based treatment interventions, which I'm going to talk about, to help maybe address some of the things we see with these kids. I will tell you, a lot of the research that I will be presenting is research based off of maybe a diagnosis associated with NAS, like ADD or ADHD. Maybe it's an intellectual deficits. Maybe it's related to children who are preterm, or children with low birth weight, or maybe this is associated with children with ADD or ADHD. There's not a lot of research out there as far as specific treatment interventions as far as occupational therapy with children with NAS or exposed to drugs in utero. So the things I'm addressing are the different neurodevelopmental complications that we see associated with children who've been exposed to drugs in utero. And remember, again, these are just evidence-based to address the different complication. Every child is different. So of course I had to start with play-based interventions for these kids. I love me some play with kids, because what is the primary occupation for kids? It's play. So let's talk about developmental play-based intervention. The rationale of this intervention is it's based off the developmental frame of reference. When we're talking about the developmental frame of reference, we are wanting to look at strategies to facilitate the child's physical, social, and psychological development in order to achieve their developmental milestones and to master daily living skills across their lifespan. That's us as OTs, right? But we want it to be fun and for play. And we want to also incorporate activities in play that's meaningful for the child. The evidence base that talks about some of the different articles reviewed about play-based interventions. They can improve motor development, improve social interaction. Now, the one research article talked about there was some limited long-term effects. Again, there was some different theories out there as to why that long-term effects may be limited. My thoughts is, well, the child maybe developed those play skills, started exploring, and their developmental skills just grew and grew. I don't know. But anyway, there is evidence out there to say how important play is for kids. I also like to talk about the importance of sensory motor exploration and play for a child's development. To me, it develops a spiraling effect to help the child. How we talked about previously, the limited long-term effects. This is kind of what I thought. As the child gets improved mobility, they improve their exploration skills, they get more sensory and motor input, it improves their learning, it improves their social interaction, which can improve occupational performance and participation. Okay, food for thought, something to think about. Another article I read, it was a qualitative study that talked about a child's perception of play. This was a very small study. I think the children's, if I'm remembering correctly, the children were school-age children that talked about what was their perception of play. And one of the first things they talked about was that they found the children preferred activities that were not too hard and not too easy. Us as OTs, the Just Right Challenge. They wanted something that was right there in the middle, not too hard, not too easy, was very important for them as far as play. These children also said they preferred play with others. They also talked about that things that have kind of challenged their cognitive skills. The children recognized changes in their own cognitive skills and functional abilities impacted their activity selection. So they kind of looked at that. And then the last thing that they talked about that they judged outside play activities to be fun and were preferred to indoor play activities. You know, again, the number one about Just Right Challenge is something I always really kind of keep in my mind, because, and we'll talk about this later slides about if things are too hard for the child, how we may see some behavioral changes, but also with others. So oftentimes I would play with the kids, because, you know, of course, if that's their perception, again, this was a small study, don't take it and run with it, but just something to think about when you're working with these kids. Another treatment, and now we've talked about play, let's move a little bit into sensory integration. Again, another specialty area of OT, a specialty area of training. Again, this was one component of the multifaceted approach that Reynolds talked about with children with sensory integration deficits. And it's an area I want to talk about with children who've been exposed to drugs in utero. So we're talking about the sensory integration theory. We know that that was developed by Jean Ayres. It's trying to provide children with structured sensory input in order to get a organized response. We know, as Neha talked about, that some of these children exposed to drugs in utero, they may have some difficulties with sensory processing. Again, not all of them. It will be up to the OT evaluation to determine if that is maybe a component that may be a problem area for the child that needs to be addressed and what interventions are most appropriate. But I'm going to just present some of the evidence out there supporting, again, the use of sensory integration with just different children. Again, I don't have the research out. I didn't find any research about implementing sensory integration with children exposed specifically to with drugs in utero. But maybe this is something to address some of the other neurodevelopmental complications we see with children exposed to drugs in utero. One of the first articles I read about, it talked about an interdisciplinary sensory enriched early intervention program. It was a multidisciplinary design. It had PT, OT, speech, and the teachers. They did multi-consultations in the home, but they also did different activities in the community with these kids. They had a caregiver and parent childhood developmental classes to help the caregivers. They also had special interventions 2 to 3 days a week for 3 hours a day, which included fine motor. They did some gross motor, cognition, social and language skills development for these children. This was a retrospective chart review study that they did with 63 children. They aged from 18 months to 36 months, which here we go, early intervention. You can see there's a lot of overflow here. Let me get to the next slide. So some of the intervention strategies they did some multi-sensory teaching strategies where they used maybe a sensory enriched gym. They allowed children to do some different movement activities. They also had a sensory, and I mean, they also did different tactile mediums and used different heights for the children to do activities like easels and inclines. They also did the sensory enriched environments. They had adaptive strategies like different seated devices. And they also used a format that tried to facilitate social interaction, where they did maybe some tabletop group activities, circle time activities, and the results indicated improvements in gross motor, receptive language, expressive language, and cognition. So, you know, you can see, again, there's evidence out there for early intervention, but maybe also sensory enriched activities. Okay. Again, there was another article by May Benson and Kumar that talked about, they looked at systematic review of 27 different research articles to look at the effectiveness of sensory integration with children. Some of the articles looked at our evidence with children with learning disabilities. Some of the other ones looked at children's with motor performance, and the research indicated that children that received sensory integration interventions showed improvement with sensory motor skills, motor planning, social skills, academic skills, play skills, and motor skills. Again, this is just some different evidence out there to support some of the different treatment interventions we do as OT. Another article I found that looked at some of the different OT treatment interventions we do as OT with kids: sensory integration, NDT, and perceptual motor. I'm not going to address NDT with this class. I'll talk about perceptual motor in just a moment, but I do want to talk about when this study, the sensory integration, some of the evidence they showed with this treatment intervention. With the children who did the sensory integration, they participated in activities to improve their sensory motor skills and sensory integration skills. They demonstrated improved upper extremity control, visual motor control, and fine motor skills. So it's just something to think about when you're working with, with children that may have been exposed to drugs in utero. Don't know if this intervention may help, but just recognize there's some evidence out there that maybe this may be an option for the child. So I introduced perceptual motor, so let's move on to perceptual motor interventions. We know that perceptual motor, what we're talking about there, looking at the cause and effect relationship between motor performance and processing perceptual information. It is a very large range of OT interventions when we talk about perceptual motor. A multitude of treatment interventions. We'll just talk about a few different activities and items to kind of look at maybe how this maybe can help children who've been exposed to drugs in utero. Again, Neha talked about that some children who have been exposed can demonstrate visual, perceptual, and motor development. Again, that's up to the OT eval to determine if this is a deficit area or not, and to see if maybe if this is an intervention that may be appropriate for the child. One of this research article was very interesting to talk about some different perceptual motor interventions that maybe can help a child. They had an intervention group. They did a combination fine motor task like cutting, pasting, dot-to-dot puzzles, tracing design, and they also performed some gross motor activities where they included some jumping jacks, skipping, hopping, and tumbling. They spent equal time in both the fine motor and gross motor tasks. And the children involved with the perceptual motor interventions demonstrated improved visual motor control, gross motor skills, balance, and strength. Okay. And we can't talk about perceptual motor without talking about handwriting, can we? We know as OTs, children spend a large percentage of their day doing handwriting activities when it comes to academia. Oftentimes, a lot of children are referred to OT in the school system to address fine motor and handwriting skills. As Neha talked about, there are some children exposed to drugs in utero that may demonstrate deficits with handwriting. Again, we have to kind of talk about that and address that when we're talking about OT interventions with children exposed to drugs in utero. So when we're looking at handwriting, we know that there's multiple components associated with handwriting. We look at fine motor skills and dexterity and hand manipulation skills. There's sensory awareness, their fine motor awareness, their gross motor skills and control, definitely their cognition and executive function, definite core strength and balance, language development, visual perception, and strength. So there's a lot of components when we're talking about handwriting. Of course, you got a holistic approach again. We got to look at the whole picture of what's going on with that child. We know how important handwriting is to academia. And we've got to look at this if we're working with a child that we know they've been exposed to drugs in utero. So I've got a couple different research studies that were done when it were associated with handwriting. One article here was a handwriting club. They had two different groups, a practice-based group and a visual perceptual motor group. The practice-based group, they did 20 minutes per session of just doing grade level handwriting activities, followed by handwriting games, whereas the visual perceptual motor group, they did 20 minutes doing visual perceptual activities, followed by 20 minutes of a multisensory handwriting program. Both groups demonstrated improvement in hand legibility and handwriting skills. So, well, improved handwriting legibility. So, you know, that just shows they both were doing handwriting, but they both did it in kind of a different approach. You know, one of them was more of a visual perceptual motor approach, whereas just a practice-based. So again, practice-based, you're still working on that handwriting and eye-hand coordination skills. But that's just to show both approaches did show improvement in handwriting. Again, the OT will have to determine what possible deficit areas are there that may be impacting the child's handwriting skills to determine what's appropriate. Another handwriting program, I read this one and I thought it was really interesting. I definitely wanted to talk about it when we're talking about perceptual motor skills, because handwriting is something we may need to address with these kids. This was a school-based OT program. What they did is they incorporated different materials into the classroom, different therapeutic materials. They did consultations with the teachers along with direct OT services. Some of the staff education had to do with what is the role of OT in the school system. The different materials that included was maybe using easels, dry erase boards, and slant boards, maybe doing tongs for different fine motor activities and different kind of scissors and games. The OT consultation is where they consulted with the teachers about how the children were doing, and then individual or group direct OT services. And what they discovered with this activity is the children developed improved fine motor skills, pencil grasp, and emergent literacy skills. When we're talking about emergent literacy skills, these are the things that the children need, various skills to help with reading and writing, like enjoyment of books, interest in books, and vocabulary. But I thought that was cool how they integrated OT into the classroom to kind of help these kids. Another article out there to support some evidence or demonstrating some evidence with OT perceptual motor and handwriting was a handwriting multisensory approach where they addressed the handwriting without tears, get set for school. They had 20 participants where they looked at utilizing the multisensory approach, and these children demonstrated improved pre-writing, kindergarten readiness skills, and fine motor skills. But you know, it's a lot of evidence out there, a lot of different treatment options out there for us as OTs. Again, it all depends on the eval and what the OT needs, what the child needs. Just a little bit more about perceptual motor before we move on to some other activities. This was just a systematic review where it was a Case Smith, Clark, and Schalbach, I hope I'm pronouncing that correctly, where they looked at, again, it was a systematic review looking at OT interventions, children age birth to 5 years. And one of the components they talked about was perceptual motor, different OT interventions. And the children developed, according to the systematic review, that perceptual motor interventions can help improve gross and fine motor skills. The one thing that I found very interesting, they talked about that children participating in therapist-directed activities demonstrated greater improvement with gross motor, whereas children participating in activities which were centered around the child demonstrated improved fine motor skills. To me, that was kind of an eye-opener to and it was something I often do in clinic anyway, kind of a combination, letting the child select an activity and I select an activity, which the evidence right there kind of demonstrated it could address gross motor and fine motor depending on what you're wanting to achieve and what activity selection is done. All righty. Whew, I know it's a lot. Y'all hanging in there with me? I know it's a little different virtual, so I'm trying. So let's talk about cognition. Huh?
All good.
All good. Okay, let's keep rolling. I hope you can see I'm a little passionate about this. I think there's so much we have to offer as OTs to these sweet loves. Anyway, let's talk about cognitive. Again, when we're talking about cognition, as Neha talked about, so many of these different drugs, if a child's exposed to them in utero, can develop deficits with cognition and executive function, which we know how much we need our cognition and executive function with daily occupational performance and participation in every area of occupation. You know, from ADLs to IADLs to leisure to play to school to work. So it's something we have to address as OTs because it can impact their level of occupation. I'm going to go back a slide. So again, when we're talking about cognitive development, again, it's our executive function, it's our memory, our attention, problem solving, cause and effect, decision making, sorting, task initiation, judgment, all those things that we need in order to be successful in occupation. So one of the articles I read, or several of them actually, talking about cognitive functional therapy interventions to help address deficit areas with cognition in order to improve patients' occupational performance. When we're talking about cognitive functional approach, they look at skill acquisition and transfer of cognitive strategies to improve occupational performance. You have to remember that there's a dynamic relationship between the child or person, the task to be performed in the environment. This approach looks at practicing different strategies in order to transfer into daily tasks, in order to self-monitor and self-evaluation and occupational performance. Oftentimes what a therapist may do is set task-specific strategies to achieve a set goals, maybe using external supports. Maybe it's using a timer for a reminder or a daily planner, or maybe you're using different games and activities to improve executive function. There was some research done with the attendants, the people they did the study with. They had ADHD, which, as Neha talked about, is a complication often associated with exposure to drugs in utero. The participants in the study demonstrated improvements in occupational performance and satisfaction, inhibition skills, behavioral shift skills, along with emotional control and working memory, which I thought was huge when we're looking at children that may have been exposed to drugs in utero. Again, just possibly another option or another tool in our tool belt, again, based off the evaluation and what the therapist deems appropriate for that child. Again, when talking about cognition, another article I found talked about, well, it was a research article that they addressed looking at children's attention and hyperactivity level, looking at the effectiveness of a stability ball on their attention. What they did is they had 8 different groups of 4th and 5th graders, and they looked at how would the effects of using a stability ball in a classroom affect the child's percentage of time seated, along with improve their time on task. This was, and I'm gonna give you the percentages, so let me read them. After they did, it was, they looked at the children, they kept times and all the other information. The participants' task times improved from 10 to 80%, and the participants' time in seat or ball improved from 45 to 94%. Again, I kept this in cognition as far as attention, you know, just to, again, another tool in our tool belt. You know, if we've got a child with some difficulties with attention that maybe it's correlated, that's impacting their academia, again, is this something that may benefit the child? I don't know. Just food for thought, something for y'all to think about. All right, social emotional. I told you we had a lot of the components of the multifaceted approach when we're looking at working with children that may have been exposed to drugs in utero. Again, as Neha talked about, there's some social emotional deficits associated with children that are exposed to drugs in utero. I remember this is not always, but it can be something associated. Again, we talked about that the child may have some difficulties with infant caregiver bonding. We also talked about they may have some difficulty with interpersonal relationships. The child may have some social withdrawal, emotional disruption, anxiety, depression, and elevated stress levels. So again, those are just some things that that we may be some difficulties we may see with children exposed to drugs in utero. Again, we all know how important social emotional development is for the child's development, for play, academics, and with a lot of occupational activities. One of the interventions that I read about, it was called joint attention. It refers to an activity where two or more individuals share attention during a task, which is associated with social interaction, social response, positive emotions, and empathy. Some of the activities they talked about that kind of facilitate joint attention is a play kitchen, playing with puppets, doll activities where you're kind of sharing and working together. Some of the things to remember if you're using joint attention, the child is to set the pace of the activity of the task. Definitely want to encourage positive emotions, provide cues to encourage sharing attention, and it's definitely client-centered play. You always have to remember what any interventions we do as OTs, that it's appropriate for the child's developmental skills and it's age appropriate for the child, and realizing just because it may not be age appropriate, I mean, it has to be developmentally appropriate for that child. Okay, so one of the results that showed with children involved with some joint attention activities, again, improved social interaction, improved social responses, facilitated positive emotions, and increased empathetic response. So just something to think about. Another thing to talk about when we're talking about social and emotional development, social skills training is one of the things I read about. I read an article that talked about, they looked at, it was a systematic review that looked at some of the different things with children, the importance of involving children with social skills training. They worked with kids with intellectual deficits, developmental delays, and learning disabilities, which those are some of the complications associated with drugs exposure in utero. The social skills training indicated increased social skills, improved coping skills, along with social interactions. So one of the things that they talked about, incorporating activities that encourage peer cooperation and team building. Okay. Again, just another tool in our tool belt as occupational therapists. And then the last component is our behavioral interventions. And as Neha talked about, children exposed to drugs in utero often can have some behavioral regulation difficulties. And we know how important emotional and behavioral regulation is in occupation and occupational performance. One of the things that, you know, when it comes to behavioral issues, I'm very passionate about this because when we've got a child, if there's something going on, I think we as OTs need to make sure we're looking at the whole picture. Again, there's that H holistic approach. What all is going on? Looking at the child, looking at the task, and looking at the environment. We've got to make sure we've got a full picture of what's going on as to why we're seeing the behaviors we're seeing. One of the interventions they talked about was a positive behavioral support. It is based off the behavioral therapy theory, where OT encourage appropriate behaviors. It is truly client-centered. We look at environmental and activity modifications and maybe teaching the child alternate behaviors. One of the things they talk about is, maybe we're wanting to prevent the problem from occurring, maybe modifying the environment, monitoring their progress. That's kind of how I talked about the child, the task and the environment, looking at what's going on. How can we make modifications to help support that child where we're maybe having better emotional regulation and more preventing those problem behaviors from occurring. Another intervention that I read about was social stories. When we're talking about a social story, you teach a social skills to either an individual or group through a story. The research indicates that it can decrease target behaviors and improve interactive communication. Again, this is through an article I read by Case Smith in 2013. So again, it's just another tool in our tool belt to think about for us as OTs. How can we do different strategies to help these kids? I like to put this board in here. This is just kind of an example of a kind of almost like a picture schedule. I love my picture schedules. Oftentimes it helps those kids get a visual picture of what maybe their day is going to be, or treatment session. I often use this in treatment. That way I get to choose and they get to choose. I get to choose, they get to choose. It gives them a sense of control, but I also have my therapist directed activities, again, addressing gross and fine motor depending on what the child needs. Sometimes, looking at environmental modifications. Maybe we need to look at what kind of external stimuli is going on with that child, what kind of environment's going on, but also the task. If the child has picked a task that may be too daunting of a task for them, how can we maybe modify it to where they're more successful in order to help address what we need them to address without taxing their system. Visual schedules, whether it be at home or at school or in your therapy clinic, oftentimes may be beneficial. Again, it depends on the child and what's going on. So, ECHO, the take-home message. I think the first take-home message is I've got to address the information that Neha so beautifully presented, and how daunting and multifaceted the neurodevelopmental complications are for children that have been exposed to drugs in utero. We know that this is an area of the complication is expanded, and more children have been exposed and the statistics have increased. But we as clinicians need to understand that it can impact the child across their lifespan, and we need to make sure we're addressing everything they need, beginning with the ECHO approach. E, early intervention. We all know that earlier the better. C, collaborative. Make sure we are collaborating, interdisciplinary, but also including caregivers and anybody involved with that child. Holistic. We got to look at the whole picture, because as y'all can see, and this is the tip of the iceberg, there's so much more information coming out about children exposed to drugs in utero, but we have to make sure we're treating the child as a whole and looking at the big picture as to what's going on. If they're having trouble with handwriting, is it just fine motor, or is there maybe something more going on? And then occupation based. That's us as OTs, beginning with developmental play. Do they need sensory integration or perceptual motor or cognitive, social, emotional, behavioral? They may not need the whole multifaceted ECHO approach. They may need just a certain component depending on where they are. But they need us to be making sure we're looking at everything that could be going on with them to address and help use evidence-based to help improve their occupational performance. All right, I'm going to pause right here to see if we have any questions.
I don't have a question. It's just a comment. I just think the statistics are just stunning. It's incredible.
Yeah, and what's frightening to me as I read it is the statistics we have. We know it's not all inclusive. We know that not every mother is, well, at least the research articles we have, not 100% honest that they have used illicit drugs. And I know one of the articles I read that talked about some children do not start to demonstrate the NAS symptoms 5 days after birth. How many kids are still in the hospital after 5 days? So the statistics are frightening, but it's not all inclusive. You know, I mean, it's very alarming, and realizing, and when you work in the school system, you don't get all the background. You know, we don't know the long-term effects. We can get some statistics, long-term effects with children exposed to cocaine. But when it comes to some of the newer stuff, we're still getting, the research is still coming out.
Do they have research or numbers on the lifelong financial impact for the individual and the community?
I did not look that up. I'm sure we could find some of that, but I didn't look that up. And you know, the statistics and research, I know one course I taught, asked a lot about the vaping and the CBD. I don't have any information on that. I'm sure more will be coming out.
Thank you.
You're welcome.
There is a question in the chat room. Why is caregiver compliance with buprenorphine less than methadone?
Let me pull that article up. Give me just a minute.
That's okay. You know, while you're looking too, I'm thinking about just what are we going into our 6th month of this COVID shutdown, and just all the stress there in early intervention and telehealth, especially in areas where it's very difficult due to logistics, you know, such as no internet access and problems with people losing jobs, or people not able to even have the technology or the minutes on their phone to devote to what's needed for teletherapy.
Yeah.
And
Okay, I
also
can't. Oh, go ahead.
I was just gonna say, to Irma's point, it'll be curious to see what the spike in those numbers will be after something where people are probably using maladaptive coping strategies at the same time that we're looking at a baby boom.
Oh yeah.
Sure. It's quite frightening. I remember reading the article about why the compliance, but I thought I had it in my notes, but I don't. I'm sorry.
No, that's okay, Cindy. What I'm thinking is, if the question's there, then you know we can email you or something.
Yeah, and the article is listed on that slide.
Well, one of the reasons, Cindy, if I may answer that.
Yes, go for it. Come
please.
on now.
So one of the reasons for lower compliance is some of the side effects associated with buprenorphine are worse than methadone. The methadone is able to is known to have this an effect that is more acceptable to a person having withdrawal from opioids or opiates, for that matter. So it's able to maintain some of the what you call a high without causing too many disturbing side effects. Buprenorphine for the mother may cause some side effects which are less desirable than what they might have with methadone. However, buprenorphine is associated with lower rates of NAS and a lower duration, a smaller duration of hospital stay. So that's kind of like the give and take you have over there. Also, with buprenorphine, 2 factors that are often not considered is the cost. Buprenorphine is more costly, less insurance coverage with buprenorphine as compared to methadone, which is another reason why mothers may not choose buprenorphine. And there's another study, the RTI study, response to intervention, RTI study, which talks about how a lot of the guidelines with respect to buprenorphine are not well known or well followed by medical providers, because methadone has just been around for a longer time and providers are more comfortable with methadone. That buprenorphine guidelines are often not followed as well with respect to its to intervention, and a lot of times that gets kind of put on the mother as being non-compliant, whereas there are issues with actually running the guidelines for this this drug. I hope that is.
Thank you.
Hi, I had a question. So I am a student at Georgia State, and I'm currently engaging in a participatory action research project through Project Scope, which stands for Supporting Children of the Opioid Epidemic. And we're working on creating educational resources for Head Start programs. So I had a couple of questions for you guys regarding compiling comprehensive and accessible resources that would eventually be disseminated to parents and caregivers. So my first question is just, where do you guys observe the greatest gaps, or rather opportunity areas in the literature regarding early interventions?
To me, when I was reading, is more the specifics as far as specific developmental interventions for specific occupational task. It's more you just kind of get a big thing versus, more specific early intervention activities. Does that make sense?
Yes, definitely.
A lot of times they do, studies will talk about like perceptual motor interventions, but they won't tell you exactly what in research has shown to work, what exactly are the interventions that you may use. And a lot of times we do know our interventions, but they have just not been classified as being relevant to perceptual motor development or being relevant to sensory integration. We know that these things work. We know that we can use them. We do use them in the clinic, but a lot of research will not go into specifics, just going off of what Cindy said. And another gap, I think, is just in research. Like, we had to go to a lot of these government websites, the CDC, the DOH, those kinds of websites to get information about the statistics. And a lot of OT research will go directly into the intervention part without really addressing how big this problem is or how fast growing it is. So I think resources definitely need to not only provide options for interventions or provide, places where intervention can be found, but first to educate about how big a problem this is. So, like sometimes you just need to have the statistics in your face to even recognize that this is a problem in my own community. A lot of times you might think, oh, I live in this excellent community, in this excellent neighborhood, or this amazing zip code with all these, $1 million homes and all these kids who go to private school. This is not a problem in my community, but that's that's not the case. It's all around you. Just look at the statistics.
Thank you. Yeah, that makes perfect sense to me. And then my second question was just if either of you two have any recommendations for providing comprehensive and, I suppose, accessible resources to parents and caregivers of children with NAS, especially if they're resources that would be disseminated by a program like Head Start, just in terms of being comprehensive and also respectful, especially considering there's a lot of social determinants of health in these cases.
Yeah, that's kind of one of the, again, I didn't really touch on the social. That's one of the big challenges, especially if you're talking about, distributing of information. And I think the hard thing is because each child presents so differently, as far as, it's just, that you can see I'm even going, that's going to be hard. It's almost like, I just keep thinking about, I know a lot of different places will have kind of guidelines as to developmental milestones. And I think if you're looking at doing, is that kind of what you're asking about, maybe, resources as far as the milestones?
Yes, so I'm on a multidisciplinary team. There's an ABA therapist, there's a psychologist. We're all graduate students, and I'm kind of representing the most clinical and developmental side. So I'm kind of compiling that information. So yeah.
I kind of would think, I mean, again, this is just me kind of thinking, making sure kind of a very broad spectrum as far as age appropriate developmental milestones. You can't just think fine motor, you can't just think gross motor. We gotta definitely look at self-care, and we gotta look at, behavior and social emotional, and where are we? But then you get into the thing that, of course, typical development, you got to be careful giving too much typical development, because then they go, oh, so anyway, I don't know, something to think about.
I think some resources that might be really helpful would be local. We are both not local to Georgia, but I'm sure, if you can, I would say, get in touch with clinicians who are working with children with NAS. And the place to start would probably be NICU therapists. So if you can get in touch with, like, I'm sure GOTA will be able to, help you out with getting in touch with therapists practitioners, therapists and OTAs who work in NICU settings, and they might kind of be your key informants to get access to resources. And the other one would be the social work team. I don't know if you have a social worker on your on the SCOPE project, but they definitely will be able to help you out with more local resource programs that might be helpful.
Maddie, do y'all have a social worker on your team?
We don't have one directly on our team, but it's through the Georgia Leadership and Education and Neurodevelopmental Disabilities Training Program, and we have social workers on that team. So I certainly have people I could.
Well, as Dr. Tripathi was saying, be sure to check with the Georgia Babies Can't Wait program. I was going to go to their website, but check with them. And what we found in our research when we were looking at something with feeding, I won't take too much time with this, but there's definitely a gap in the silo of the NICU and then early intervention. Things just don't get communicated. So we could talk more about this later, but that's look at the early intervention program here in Georgia. And then if you've got some connection with any of the NICUs, the big ones at Northside, and that's a real problem.
That's great. Thank you so much to all three of you.
Good luck. That sounds like a really cool project. Any other questions?
We are looking at about 10 more minutes, so just wanted to let the presenters know this.
That's what I noticed. For time is a ticking. Anybody else? All right. Well, we'll just go ahead and just kind of wrap it up. I know that you had mentioned the gap with the NICU and the early intervention. You know, that, again, if you are working in the NICU, again, that can be something to kind of look into, because bridging that gap from the NICU to the community is so important, to make sure that continuation of care. Again, you know, a lot of times you're working with the neonatologist that transition to the pediatrician to make sure the continuity of OT, and do they need continued OT once discharged? Having that conversation. Again, the ECHO approach is just is an approach that Dr. Tripathi and myself developed for these kids that have been exposed to drugs in utero. Again, every one of these children present very differently, recognizing they could have a multitude of neurodevelopmental complications, both short-term and long-term, that can affect occupational performance across their lifespan. Realizing that the different treatment approaches discussed, it all depends on the child, starting with that OT evaluation, looking at some of the different layers as to what's going on with the child, again, in order to enhance their occupational performance. I hope this information has helped. There's a lot of information out there. This was just the tip of the iceberg. When researching the information, I just had to get to a point that I had to stop, because there's so much out there. I think we're going to continue to see more and more research come out about drug exposure in utero and interventions. So I hope y'all find this information helpful, and thank y'all for joining us.
GOTA thanks you too. And I think we've got a nice springboard to where we can go with this. I see us maybe talking about some resources and some ways to make some connections. Thank you all for participating and being here tonight. This is such a timely and important talk. Be sure to fill out your assessment so that you can get your continuing education. And I hope that we'll be hearing from you all again, Doctors Ayo and Tripathi. Okay.
Thank you for having us. Thank you, thank you, thank you.
We gained a lot. Our pleasure. Good night, everyone.
Good night.
Nice.